Thank you all for joining. Sorry for the late submission of the link. Before we start and before I hand you over to Nick Booth, who'll be introducing today's session, I'd just like to go through a few housekeeping rules with you. Could I ask you all to please remain on mute during today's presentation? We do have a Q&A section at the end, so please feel free to unmute then and ask any questions you may have. Also, just to let you know, today's webinar is being recorded, which will be quite helpful for those who are not able to join. And yeah, that will be available on the faculty website and YouTube channel. And lastly, we do have an evaluation form. So if you do have a few moments to complete it, that will be great. I'll pop the link in the chat function. It just gives us a bit of feedback on today's session. And also helps us improve our webinar series going forward. Thank you. I'll now hand you over to Nick Booth.
Okay, well, massive apologies on behalf of the Faculty of Clinical Informatics for our email glitch in not informing everybody in a timely manner of the link. This is now being recorded, so it'll be available in its entirety to people who didn't manage to join. So if you know anybody, let them know. And I will now introduce Ewan Davis. So you can probably see him. He's not the same guy that introduces Dragon's Den or does the 5 o'clock news on BBC4, although he has got a remarkable similarity in his youthful face. I've known Ewan since my very early days as a health informatician in the 1980s, when he was the supplier of my first GP clinical system. What Ewan doesn't know about clinical system interoperability isn't worth knowing about, and he's now going to tell us his latest thoughts on beyond interoperability. So, Ewan?
Yeah, Nick, if you'd like to share the first slide.
That one?
Yeah, so just a little bit about me. I can see from the list of people that there are 1 or 2 people on here who know me and quite a few who don't. The first thing I should say is I appear to have managed to log on to Teams with my NHS Digital account. That was unintentional. I'm not speaking on behalf of NHS Digital, but on my own behalf. It's a horror, but I recognise that I've actually been working 40 years in what we now call health informatics. I was founder of one of what at the time was a large GP system, and at least a couple of my ex-customers on this call, all I can say to them is sorry. I'm past chair of both the British Computer Society Primary Care Group and of what is now called the Tech UK Healthcare Group. More recently, I was the principal author of Defining an Open Platform, which I wrote for the Aperta Foundation. I first worked on interoperability back in 1987 with some links between Birmingham and Oxford laboratories and GP systems. It worked rather well because we didn't know that it was difficult. Later been involved with ASTM 1238, HL7 pretty much from its beginnings, and then for a period with Edifact. I worked for BT along with Nick and 1 or 2 others on this call, where I had some involvement with HL7 version 3, which was a very painful experience. And more recently, I've had an attempt, I think I have to say a failed attempt at a startup with Inidus trying to promote systems based on OpenEHR. I am currently working with NHS Digital on medicines interoperability with FHIR version 4. But as I said at the beginning, I'm not here speaking on behalf of NHS Digital. Next slide, please, Nick. So what is it that we're trying to achieve with data interoperability? Well, I would describe it as data fluidity. It's about enabling the sharing of relevant patient data along care pathways to support care. We need it because we need to engage patients and their family and informal carers in the patient's care. And we want to do it to make data accessible for a whole range of analytics purposes, make it available to AI. And we want to enable innovative applications, to access health and care data that's in the existing infrastructure. Next slide, please. So if we talk about, there are various modalities for sharing data. So the first is the interoperability modality. And in this approach, you transfer data between heterogeneous systems. So, and this is the real world as it is today. Each of the systems out there has data recorded in its own, typically proprietary data structures. So we try and map the information from those data structures into some common format. And really the only game in town and the right choice at the moment for that common format is FHIR version 4. So each system vendor has to map their data into that common format, and at the receiving end, they have to map data from that common format into their own internal proprietary data structures. This approach can achieve the transfer of high-value information. So we can share things like medication and problem lists and allergies, but there are a number of difficulties associated with this modality for data sharing, which I'll talk about a bit later. Next slide. So I've included this one for completeness, but actually I'm not aware of anybody who's trying to do this. But in this modality, all systems would use a common, would have a common set of shared semantics. So the internal data structures of each system would be identical. And in that situation, you simply lift and drop data between system 1 and system 2. There's no need for any mappings or data transforms. But as I say, I'm not aware of anybody who's doing this, because most people who are moving towards shared semantics are going down the route of the next modality. Next slide, please. And that's the platform approach. So in a platform architecture, you separate applications from the data that they're operating on. This is an approach that's been around for a while. Platforms are really important in other sectors. We see it in banking with open banking. The whole of the infrastructure of travel apps and travel websites is based on the fact that there is a platform for travel, which is the Sabre platform, which I think was first developed in about 1964 as an airline booking system by IBM. So platforms have been around a long time. And in a platform, you simply expose data in the record via a standard API. Now, a platform approach doesn't necessarily require that the systems in the various EPRs connected to that platform have shared semantics. So a platform can operate in a way that's similar to either of the first two methodologies. It can work by mapping data from source systems into that common API, or it can work by adopting a set of shared semantics across the various EPR systems, and that avoids the need for mapping, and that takes us on to an approach which I would describe as an open platform. So an open platform is defined in defining an open platform. The title says what it does on the tin. And in an open platform, data in each EPR is stored in a common format. And really, the only game in town, if you want to have a common format for sharing data in that way, is Open EHR, which his friends call Open Air. So platforms. Next slide, please. Whichever of the approaches that you take, whether you're looking at an interoperability model, where you're wanting to exchange data between heterogeneous systems via a common format, and really in terms of much of the short-term benefits that we can gain, that will be the modality that we want to pursue, or whether you're wanting to move towards an open platform with shared semantics, there are shared challenges that have to be faced. I don't know whose Guardian notification that is, it's not mine. So the first challenge is that you have to define clinical content. You have to define what you mean by a medication or an allergy or a blood pressure or a weight or a temperature in a common format. The second challenge you have are those raised by context and provenance. So when you're looking at a medical record, knowing the context in which it was collected and who collected it can have a significant impact on your interpretation of that information. And I'll talk a little bit more about context, because I think it's an issue that's ignored by many people looking at interoperability, because we lose context and in many cases we lose meaning. Next slide, please. So the first thing to say about defining clinical content is that it's hard. Those of you, and I can see there are a number of you on the call, who sat in curation meetings, whether it be OpenEHR or FIRE or whatever it is, will know that this is a slow and painful process. And there are reasons for this. First of all, care data, I would suggest, is uniquely complex. Certainly, I can't think of any examples of data that is more complex other than some rather niche areas. Whereas care data is something that is ubiquitous, it applies to all of us, and it is incredibly complex. Those of you who are working with it will understand this. It consists of narrative text, it consists of coded data drawn on a terminology system, SNOMED, with in excess of 300,000 distinct concepts and 1 million synonyms. It includes images, which ranges from little sketches that GP makes where X marks the spot of the lesion to complex multi-gigabyte CT studies. It includes signal data from ECG machines. It includes sounds. It includes video. It is complex, and much of the information in that record is represented by relationships between those data elements. And that brings us again back to the issue of context. We often hear, usually from ill-informed politicians, comparisons between banking and healthcare. And it's one of those things that always irritates the hell out of me. The data in banking is really simple. It is a sum of money which can be represented simply by a number and a currency. What banking systems do is they move money between one account and another. There is some complexity surrounding it because people don't want it to be stolen and they don't want it to be lost, but you're dealing with a basically very simple data elements. Care.data is at the other end of the scale, extremely complex, and that's one of the sources of difficulty. The second problem is variability in use cases. What a GP wants to do with the blood pressure is very different from what an intensivist wants to do with the blood pressure. And to try and come to a common view of what we mean by a piece of clinical content is hard. I think it's commonly said that you get 2 doctors in a room and you get 3 opinions. Many of us on this call have sat in those meetings. But if you're to move forward with any modality of data sharing, you have to crack this problem. You have to find a way of representing clinical data which can meet the use cases of all of those users. And that's a hard problem. The next point is an understanding that this is not a technical problem. We have technology which will allow us to share data. We have plenty of methods of doing it. The challenge here is the clinical challenge of defining a clinical content. And that leads me on to my next bête noire, which is the fact is that the people who are leading the NHS IT do not understand the problem. And we have seen a series of appointments to senior positions in roles where they're responsible for interoperability from people who had no prior experience in the healthcare sector. And until we have some leadership in NHS Digital, NHSX, from people who do have a background in healthcare and people who have been in the trenches of interoperability, we're not going to make progress. Because this failure to recognize that interoperability or defining clinical content is a hard problem leads to naive solutions, the sorts of comparisons with banking that I referred to earlier, and they're doomed to fail. Politicians, senior officials, people new to the sector, often really clever, personable people. These are not bad people, but you're not going to understand this problem, let alone solve it, if your background has been in Jaguar Land Rover or Cadbury's or wherever else it may have been to cite recent appointments. Cracking this problem requires an understanding of clinical data and processes. It requires experience, which enables you to realize how hard that problem is. And until we have that, we're not going to make progress. Next slide, please. So, what do you need in order to crack that problem of defining clinical content? For the creation and curation of those models that represent clinical concepts. First of all, you need a methodology. That methodology has to be agile. If you can't satisfy the needs of developers who say, I want to share information representing visual acuity with another system, if you can't give them the definitions and the components that they need to do that using a standard, they will do it themselves, they'll do it their own way with some proprietary solution. So we've got to be able to respond quickly to the needs of developers who want to share a new piece of information. The methodology has got to be accessible to frontline clinicians. It's a clinical problem, and that means that clinicians need to be the leaders in the process of defining clinical content. But in order to participate, most clinicians do not want to go through a painful process of learning a concept, an obscure methodology for defining clinical content. If I go back to my experience with HL7 version 3 and its use in the national programme and the wonders of the MIM, the Messages Implementation Manual, that was so impenetrable that it was only understood by a tiny cadre of the priesthood, who as a result could charge amazing consultancy rates, but simply wasn't accessible to anybody who simply wanted to bring their clinical experience to bear to help define content. Clearly, with any methodology, there is something of a learning curve to learn how to use that methodology and its supporting tools, but it has to be accessible to the clinician who's computer literate and is willing to, maybe attend a one-day course, but it can't be something that is only accessible to the high priesthood of interoperability. And it has to support focused and asynchronous engagement. So what do I mean by that? By focused, I mean, if you're an ophthalmologist and you're interested only in visual acuity and visual fields, you don't want to sit through a meeting that's discussing all sorts of other stuff in which you have no interest and can contribute nothing. So it needs, the methodology and needs to allow experts to give their input in a focused way that takes as little of their time as possible. So focused. By asynchronous, you need mechanisms that mean you don't necessarily have to be in the same place at the same time. This is partly because it's always very difficult to coordinate people's diaries, but it's also because, and I'll come to this later in the next point, this is a global problem. We need to be sharing the definition of clinical content with colleagues across the globe. And those of you who've tried to work, particularly with Australia, will know that it's not easy to arrange meetings in common time zones. So we need a mechanism for asynchronous contribution. We need a community to support that methodology. And that needs to be a global community, because this is a big problem and it's not going to be solved by one country or one vendor. So we need to build a community of people with the expertise to contribute to the definition of clinical content in their area of expertise. We need tooling. We need tooling that supports the methodology. We need tooling for editors, and that needs to be clinically accessible, because our editors are predominantly going to be clinicians. And we need tooling for developers, and that's going to be technical. It's going to give them computable artifacts that they need to incorporate into their system. Finally, last but definitely not least, we need governance, because without governance, all attempts at data sharing will fail. If you don't have a way of enforcing your particular implementation of the standard within your health community, you will not achieve data sharing with FHIR. You will not achieve data sharing with OpenEHR. You have to have a mechanism for governance, probably operating in the our context at a UK level, may end up at a home country level, but that governance has to be agile, going back to my initial point about the methodology. The reason that people go and do their own thing and produce yet another non-standard way of representing something is because they can't get a standard representation of that quickly enough for their needs. So we can't have ponderous committee structures approving and reviewing standards for clinical content. And that's particularly true because no committee of worthy people is going to have the knowledge necessary across the domain anyway to make a meaningful contribution to that process. So that governance has to do two things, and it needs to operate at multiple levels. There needs to be global governance around a particular methodology, but there also needs to be governance at the level of an individual health community. And that approach is one that has to encourage convergence. So where possible, we all use the same standards for representing a piece of clinical content. But it also needs to support the inevitable dissonance you get. And the fact is that sometimes it simply won't be possible to have an absolutely shared standard. That's particularly true at a global level. Things will be different in different countries, but it's also true to some extent at a more local level that there will sometimes be needs to say, actually, we can't agree on that and we're going to do it slightly differently for our particular use cases. And the governance framework and the methodology has to encourage convergence, so we don't want that to happen, but it has to support that dissonance when it's inevitably there. So next slide, please. So I want to go back to context and provenance. So context, why was this, where and why was this information collected? And what other information about that patient surrounds it? Because so often that will substantially alter your interpretation of that information. And seeing a piece of information in isolation about a patient can often be misleading. And there's a tendency with the interoperability approach that you lose context. You share the details of a person's medication, but you don't share details about that patient's employment, about their problem list, about their family circumstances, which can significantly alter what that information might mean to you. I mean, if I take an example, if you see a medication item for a beta blocker, you might take a different view of what that means if you know that that person is a snooker player. So the context of information often affects its interpretation, and we have to be very careful when we take some elements of a patient's record and transfer it to another system and lose that context. And that is probably an inevitable consequence of the interoperability approach to information sharing. If we move on and talk a little about provenance. So provenance is about who recorded the data. Because if a piece of information has been recorded by the junior doctor in an A&E, it has a slightly less certainty than if it's been recorded by the eminent specialist in the area relevant to that piece of information. So if you don't know who has recorded a piece of information, that can affect the interpretation of it. And very often, the provenance of information is lost when you move it between systems. The systems may share who recorded it, but you probably don't know anything about that person, so you can't interpret its meaning. So this is a hard problem. I'm not entirely sure how you solve the problem of provenance. I did think we could have a sort of voting system where you could upvote or downvote the views of other clinicians, so as whether they're reliable or not. I'm not sure that's workable. And as I say, context is typically lost with interoperability. What you're doing is you're sharing an allergy and medication, a test result, in isolation of the other information about that patient. So next slide, please. So my conclusions. So the first thing is that this is not, the problem of sharing data is not a technical problem. Clearly, we require certain technical tools to do it, but those tools exist and work. But what we need for success is for the process to be led with people who have a profound understanding of care processes and data, not by technical people. Technical people have a key road to play, and I probably would have to acknowledge that there are some technical people who picked up that profound understanding of care processes and data. Maybe I have. I'm a technician by background, but 40 years working with doctors, I can hold my own. Indeed, for many years, the chair of the GMC Professional Standards Committee thought I was a doctor. So if I could fool her, I could fool anybody. So we have to understand that it's a hard problem. And we're only going to do that if it's led by people who understand care processes and data, and probably by people who've been in the trenches, who've sat in those interminable meetings where you're trying to decide what the difference in the FCI medication statement between based on and define and derived from actually is, or how you represent the causative agent in the FCI and allergy intolerance profile, or whether you need another element in the OpenEHR blood pressure archetype. These discussions are hard, and coming to a sensible conclusion is difficult. Whichever approach you take, whether you're trying to promote interoperability between heterogeneous systems and practically to achieve benefit in the short term, that's what many of you are going to have to do, or whether you're taking a longer term view and trying to move towards an open platform based on shared semantics. Both of those approaches need a robust process for the definition of clinical content. I think probably the best example of something that currently exists is the methodology for defining clinical content in OpenEHR, which I think is more mature and more robust than the equivalent approach in the FCI community. My great sadness is that those two communities haven't taken a common approach to defining clinical content, because that's certainly practical. Define clinical content and then use it in the context of FCI or OpenEHR. Sorry. Finally, although my personal belief is that we need to move towards open platforms and we need to move towards shared semantics, that's clearly not a short-term solution. So interoperability is important, and we need to get more of it. FIRE version 4 gives us a very satisfactory tool for that sort of interoperability, but it won't deliver the data fluidity we need, and typically does not preserve context and provenance, which can be so important in the interpretation of the EHR. So that's really it from me. What I want to see is a robust approach for defining clinical content, preferably one shared by all of the different methodologies. And I want to see leadership who understand that it's a hard problem. Thank you. I'm now open for questions and comments.
Thanks very much, Ewan. That was incredibly clear and succinct and penetrating. So I'm asking people to put into chat any questions, and while they're gathering themselves to do that, I've got one for you. Have you got any advice for the Faculty of Clinical Informatics, how they might interact with senior leadership in, say, NHSX to enrich the discourse about interoperability?
I think the message has to reach senior levels in government that this is a hard problem and it's a clinical problem, and it's one that should be led by the clinical professions. I mean, in this context, I've been very disappointed with PRSB, which in my view is the sort of organisation that should be leading this within the UK. But I'm afraid that the PRSB is very much the tail wagged by the dog rather than the dog wagging the tail. That probably leave a few people leaving the call, I don't know. But this is a clinical problem and it should be led by the clinical professions. And that hasn't happened. So whether the faculty has a role in that context, I don't know. But I think we do need that sort of organisation to provide the governance required within the UK healthcare system. And many aspects of PRSB would fit that requirement, but it hasn't, in my view, lived up to that approach. Rather, it simply responds to requests by techies in NHS organisations for bits of rubber stamping.
Okay, thanks, Ewan. I kind of agree with that. I think Colin has a question. Colin, would you like to unmute yourself and put your question?
Okay, thanks, Nick. Yes. How do you think we can incentivize the commercial suppliers to adopt the published open standards rather than continue to invent their own varieties?
I actually think there's a willingness amongst the vendor community to move towards these standards when it brings obvious benefits to their customers. You know, as somebody, say, I was once chair of the vendor association, so I've definitely seen this from both sides. I think people develop proprietary solutions predominantly because there isn't an open one, or there wasn't an open one. Once you've invested a great deal of time and effort in creating your solution that works and is based on a proprietary data model, you're going to be very reluctant to change that. And I think what vendors want is clarity and stability. You know, so at the moment, we have FIRE version 4, which is the first normative version of the FIRE standard. We need to be clear to vendors that that's going to be the standard de novo for a while, and that we're not going to be asking them to move to FIRE version 5 next year. Or we have to tell them that we are going to move to version 5 next year, and that's going to be the standard for a period of time. So I think what vendors want is stability and clarity. So clear implementation guidelines, the opportunity to test those standards with other vendors, which has happened pretty successfully within the work that IHE have done with their connectathons, and work that more closer to home that I've been involved in the medicines interoperability group, where our hackathons have been a very effective way of taking out those final wrinkles. Because you find if you you define a fire profile to exchange medication information and you give it to 2 vendors to implement it, those 2 implementations won't talk to each other. If you've done a good job at defining that profile, they won't be all that far out. But the way you shape that out is by actually getting all the vendors into a room, getting them to actually try and interoperate, and they'll then realize that their interpretation, a perfectly reasonable one of what the guidance says, and somebody else's interpretation is different, and they'll shake it together. So that sort of process, which I say was pioneered by IHE on a global basis with connector-SONs and has been picked up very successfully by NHS Digital, certainly in the area that I've been working in medication, and I guess elsewhere in terms of getting those the UK core fire profiles to work. So, because I think by and large, for many vendors, it's in their commercial interest to support interoperability. I think there are potentially a few large vendors for whom that's not necessarily the case, and they see commercial benefit in their quasi-ownership of the data. And I just think we have to press on those vendors to move towards open standards. But I think a willingness to adopt interoperability standards is actually there in the vendor community if you give them clear definition of what you want, if you create stability in that, and if you can demonstrate the real benefits to their customers in having that capability.
Thanks, Ewan. There's a question from Charlie Martin. Charlie, are you in a position to pose that yourself?
Yeah, it's question / comment, because I agree PRSB isn't really helpful, and when you're trying to do interoperability programs, you want your clinicians on the ground to play an active role in that standardization, but they don't have the time. So I was wondering if you have any kind of courses, or maybe there should be a course put on the e-learning for healthcare website around API standards. There could already be one. So it's kind of, if there is one, where is it? And should there be one?
There are plenty of, there's plenty of training material available. There's lots of stuff on YouTube. There are courses run, particularly around FHIR and OpenEHR. I'll make available some links to those after the call. I think it goes back to, if you search YouTube for this, you'll find something.
Yeah.
Because there's always a YouTube video, whatever you want, there's always a YouTube video on it. And there are some quite good ones around both of those standards. I think the point you make is an important one, and it goes back to what I was saying about the accessibility of a methodology and the need for focused, allow people to make focused engagement. If you're dealing with something which has general clinical applicability, like a blood pressure, then clearly you can just take what's off the shelf and use it. That's already had enough clinicians pore over it that it will cover what you need. But where you're moving into new areas, and the examples I cited were in ophthalmology because that's a real example, and you're dealing with something like visual acuity, where are the really only 3 or 4 people in the world who are going to be expert on that, and nobody else is going to disagree with their view. There's somebody at the Moorfields, there's somebody at the Mayo, there's somebody in Tokyo, So as long as those people can engage, and they're not interested in spending hours and hours looking at other aspects of interoperability, they're only interested in ophthalmology, let them engage. So, not all clinicians can engage in defining clinical content. We need to get enough engagement. And the model that OpenAir follow is one we call the duocracy. And it's very similar to the Wikipedia model. If you feel strongly enough that something needs to be done or isn't right, you can get in there and change it. And if others agree with you, then that change takes force. If you just want to sit there and moan about it and not willing to do anything about it, then sorry, but nothing's going to change. So you need a methodology that's open for people who feel strongly enough that something needs doing or needs changing.
Yeah. Oh, thank you.
I think that is the case with both of the standards. If you feel strongly enough and want to get engaged, you can.
Thank you. That's really helpful.
Thanks,
and
Ewan.
I'll share a few links of what I think are the better pieces of sources of information after the call.
Thanks, Ewan. We have another question from Cheryl Way, which I'll quickly read out. Why is NHS Digital using FHIR rather than OpenEHR?
I'm beyond my pay grade. I mean, I think both have a place. So OpenEHR is very much around open platforms, shared semantics. It takes the view that the only way you can achieve data fluidity is by standardizing the way you represent clinical content. From a personal perspective, I believe that's the future. Not necessarily OpenEHR, maybe son of OpenEHR, but open platforms where you separate the data from the application and where you store that data in a common format. So you avoid the problems inherent in mapping and transformations between different ways of representing the same thing. So if you want to go down that open platform route, then really the only show in town at the moment is OpenEHR. There's some interesting work coming from Tim Berners-Lee and the Solid community, which is based on using FHIR, but that's much less mature than OpenEHR. But let's see where that goes. It's really quite interesting. If you want to do interoperability between heterogeneous systems, and the reality is that in the short term, that's the thing that will give you the most immediate benefits. You can share meds, allergies, problem lists, test results, and indeed a lot of other stuff as well. You have the inherent problems in that every vendor has got to map to and from that structure, and you have issues of loss of context and provenance. But I'm not at all suggesting that interoperability can't deliver some really valuable benefits. So it can, and if that's your game, if you're about sharing data between heterogeneous systems, FHIR version 4, which sort of builds on the success of HL7 version 2 and the failures of HL7 version 3 is really good. Having spent quite a lot of time in the innards of FHIR 4 over the last 12 months, it does the job and it does it pretty well. So we need both. I say my sadness, and I think probably the time for this to happen has now passed, is that we don't underpin both of those methodologies with a common set of representations of clinical content, because that would make it easier to migrate from an interoperability model to an open platform model if that interoperability model was using the same clinical content definitions as the open platform that you're going to. It's actually, you can use OpenEHR in this approach. So OpenEHR has this robust mechanism of defining clinical content. It has the advantage that it's a maximal data set approach. So when you have a maximal data set, it's easier to get agreement between clinicians, because if somebody thinks something's important about blood pressure, you put it in. FHIR, and this is a slight simplification, FHIR tends to lean towards being a minimum data set approach. So we could have used OpenEHR to define clinical content, and from that we could have derived the FHIR resources that we need for interoperability. That did actually happen. If you look at the medication and allergies work, you'll find that is actually based on common work across those two communities. But sadly, that didn't spread. And we're now seeing a lot of independent development in the FHIR and OpenEHR communities. And I think the time for a common approach, we've missed that opportunity. But we need to answer the question. We need both. And certainly within the NHS, both are being used.
Okay, thank you.
There's a question from Sapna, who's at Addenbrooke's, I think. Do you think there's value in sharing free text data in conjunction with structured data to help provide context and provenance?
Yes. I don't think everything has to be structured. And I think that's one of the pitfalls in data sharing. Some information cannot be usefully structured. And it's very difficult to represent some subtlety in structured data, and the only way you can hope to communicate between the sender and the receiver is with narrative text. So I spent a certain amount of time arguing with people who want to share a piece of information and are wanting to make that structured, and I can't find the use case of making it structured. You need data to be structured if you want to compute over it. If you want it to transfer meaning between two clinicians, then perhaps free text has a very important role to play, and it should be shared as part of that interchange, and should be available within that platform. In terms of using free text, FHIR has within its definition provision for a textual representation of the context of the profile or resource. It's not always used, and I think there's a current discussion going on about whether we should do that or whether we should just provide the structured data. So yes, I mean, I think free text has a role, and it certainly fits within the available standards should you choose to use it. And I think if you're finding something really difficult to represent in a structured way, you should always ask yourself, is there a need for this data to be structured?
Thanks, Ewan. We've got one final question from Polly Bishop. Polly, could you give your question? It's quite long in the chat.
Hi, thank you, and thank you very much for the presentation. I'll keep it short because we're just coming to an end. It wasn't really so much a question as a comment, unless you want to reflect on it, Ewan, which was, I think that we need a real broad range of disciplines involved in this. You've obviously said clinical is key for leadership, and it's not just technical. There's also obviously data governance and ethics specialists, and I guess the concept of sharing everything and the contextual information is almost diametrically opposed to the view that one should only see and access the information that's needed in the moment, and data should be, really honed out. Access should be honed down to what's needed at that point. So I appreciate that. That's I guess it's just a different perspective, and that's a real complex consideration in addition to what you
yeah, I think it's a very valid point. Because it's not necessarily, it's very difficult to say what information does the clinician need in a particular context. Yeah. When I'm talking about governance, I was talking about governance of the standard rather than governance of access to the data, but that information governance piece is clearly very important. And how we represent some of the markup to indicate within the record, because that's a problem at the moment, because we don't know. It was a particular challenge in GP to GP record exchange, the problem of third-party data. My wife says I drink too much, recorded by the GP, or next door are concerned about how Mrs. Brown is treating her kids, recorded in the GP record. That was a massive problem because there was no way of identifying it. So one of the things we have to think about when we're talking about context and provenance and is markup of records. So if that had been marked up as third-party data, we could easily have excluded it as the law required. So yes, and the whole ethics of data sharing is clearly an important problem. When I say clinicians, I of course include the broadest possible group in that, all of the clinical professions and probably clinical scientists as well. But when I say it's not a technical problem, it doesn't mean we don't need technical people. We need technical people to support the clinicians in that, and we need people with a role in information governance and ethics and all the rest of it, supporting that process. But it needs to be clinically led. And it's not. And if I look at the people who are appointed to roles that have interoperability in their title recently, very clever people, very, very personable people, but when I look at their LinkedIn profile and see that they have no experience of healthcare, I just cry. Thank you.
Thank you.
Well, thanks very much, Ewan. Sadly, we've run out of time. I'd just like to thank you, Ewan, really very much for a fantastically good talk. Your wisdom is shining through as ever, and maybe you could apply for the next job as Chief Executive Officer of NHS. Shalane has put an evaluation form at the end of the chat, and we would be really grateful if you could all fill this in before you leave. But thanks very much indeed, Ewan. Very, very appreciated.
Thank you, and thank you for everyone. If anybody does have any further questions or is looking for pointers at some of the stuff I've mentioned, I will put something together and share that with the faculty. But if that doesn't cover what you're looking for, please feel free to email me and I'll try and answer your questions. Thanks.
So I think that the YouTube channel should be carrying this presentation by the beginning of next week. Is that about right, Shalane?
Yes, it is. Yeah, it'll be. Everyone will receive an email as well once that goes up onto the website and
Okay.
channel.
Well, thanks very much, especially for your patience at the beginning when we had a bit of a glitch in getting people to join up. But it's been a very worthwhile session, and thank you all for coming. Bye-bye now.